Healing the minds. What's mind? How do you go about healing it? If you don't know what mind is, then how do you go about healing it? We know what mental illness is, what happens when mind goes wrong. But if a person, like if you have a observer which looks into the whole system, if you have a broken limb, we know that it hurts and then we need to go and get it better. But if the system which is supposed to observe and monitor, if it fails, how is that we are going to know that it's going wrong? How is the person who is going through a psychological illness go about seeking help? Certain things probably are very easy. For example, a patient gets anxious or depressed or sad, it probably is much easier. But if a person believes that somebody is haunting them, troubling them, following them and monitoring them with chips and cameras and all those things when there is no evidence, how is that the person needs to develop an understanding into what's happening and then go for treatment? How do you go about heal these minds? And how do you go about the minds which have been compromised, perhaps having a trauma during pregnancy? If a mother develops a major infection when the child is in the womb and the child is born with low birth weight and reduced intellectual ability, how do you go about dealing with it? And if you have another spectrum of illnesses wherein the child cannot connect to the world, as we call it autism, wherein the child doesn't see the other person as somebody with the same thought process as you have, to put it in scientific terms, the person who doesn't have what is called a theory of mind. So how do you go about helping these individuals? So healing mind and healing the minds is a very difficult and a tricky task when compared to healing, say, a broken bone or an ischemic heart disease, wherein you know that a blood vessel is blocked, you somehow manage to open it. If you cannot open the blood vessel, then you create a bypass. But in the mind, the person will not come in and say, like, I have pain here and this is something you need to do. The person would come and say, like, oh, this is what's happening. So the observer, the physician or the clinician has to make the other person look into themselves and report the phenomenon. There is no stethoscope to look into the what you call the process of the mind. There are only markers to know that there is a sort of a tiger which is roaming around in the jungle. Most of the time you might not see the tiger, but you might see the pug marks. So brain thought process leaves certain traces which will lead to an understanding of psychological problems. Then comes the biggest question. Why is it different from normality? Like, people can be depressed or sad when they lose their loved ones. They can go through grief. But there is something called pathological grief, which is quite distressing. So normality, to run through quickly, can be an ideal normality, wherein people can, in an ideal term, should have 32 teeth, which most of the people don't have. So that's called an utopian or an ideal normality. And then you have a statistical normality, wherein certain, like if you say like people with an IQ, statistical normality, then example in psychiatry would be learning disability. If you have an IQ of 70, then you're considered to be sort of normal intelligence. Anything less than that is learning disability or mental retardation. And anything more on the higher side, like falling beyond the bell curve, would be exceptionally genius, or much below would be considered as very low IQ or very severely learning impaired. So that's what's called a statistical normality. And there could be cultural normalities. Being possessed by gods in certain cultures is absolutely normal. People consider, like, every Friday this particular woman gets possessed by this particular goddess, Durga, and then she gets better in a half an hour. She gives advice to people and she's fine after that. It's a cultural norm. So things beyond that, which are quite disabling and distressing to individuals, is the biggest hallmark in psychiatry, because there is no evident blood test in psychiatry. So it relies more on observation, examination and clinical interview. So clinical interview and examination of the patient becomes the primary investigative tool in psychiatry. And of course, as we are evolving better, we now get a few more biological markers, especially in conditions like dementia. We have MRI, that's scan images which show that there is shrinking of brain, and though brain biopsy is not a routine thing, but we know that the white cells and gray cells tend to shrink in dementia. And imaging studies also show that in schizophrenia there is a lower functioning of frontal lobes, that the front part of the brain seem to function at a very lesser level in comparison to other parts of the brain, which leads to impairment in judgment and thinking and ability to find abstraction, which is a very highly evolved skill as on the evolutionary scale. So we are gently moving towards some biological markers, i.e. a blood test to look at serotonin, which is not used on a routine basis, or a scan or an imaging technique. But at the current time, still clinical interview and interviewing the patient is still the major tool in psychiatry. In the past, healing minds was done by shamans or religious healers or exorcists. People were drilling holes into the skull. It was called trephining. People were putting holes into the skulls of patients. This is what you call a 2,000-year-old skull, which was found in South America, wherein it was done by instruments in order to extract the spirits or let out the evil spirits out of the head. So from healing through shamanistic ways, or exorcisms, or hitting people or killing people at burning at stakes, we have now moved into a very modern era of healing the mind, and we have learned a lot from the history. History has taught us that perhaps healing doesn't happen by punitive treatments or punishments, but much more kinder, humane and medical ways of treating with the help of psychological and social mechanisms, and integrating in a community model seems to have taken much more priority, especially from 80s onwards. With the advent of chlorpromazine in 50s, along with lithium. Lithium is a very interesting molecule. Chlorpromazine is a drug which was discovered in 52, and later in 54 lithium was produced. And prior to that, of course, we had a few other treatments like cutting parts of the brain, which would be considered very barbaric. Lobotomies were done in the past, which is very refinedly called psychosurgery, but people were really chopping off decent amounts of brain, putting a knife or a sharp instrument from the eyes or nose into the brain and chopping it off. So that's something, from that we have moved on in a significant way, and electroconvulsive therapy or shock treatment. We have now gently moved into an area wherein we can finally target specific parts of the brain with specific neurotransmitters or chemicals or medicines, which can alter behavior significantly and lead to better integration without having major side effects. So the goal is now, earlier it used to be like a mentally ill person, a treatment goal would have been, whatever happens, just make this man sit at a place and be calm, that's more than enough. Now the treatment goals are complete reintegration into society to live so-called, what in quotes, a normal life. Being married, being productive, being able to hold a job, and being able to lead a very functional and productive life in the community. So those are the treatment goals now, and we are able to achieve that. We use a biopsychosocial model. Bio means biological, that's dealing with physical body in itself. Psychological, that's dealing with the thought processes and emotions. And social model, that's dealing with environment and the society around. I'll quickly run through the biological treatments which are currently done. Psychiatry especially relies, or mostly relies, on pharmacology or medicines to deal with mental illness. We have a huge range of medicines, And you also have electroconvulsive therapy or shock treatment. And there is something called vagal nerve stimulation. There is a particular nerve called vagus nerve which is in the neck, and it can be stimulated repetitively, especially in depressions. And now we have this interesting new mechanism which has been gaining a lot of popularity in the last decade. It's repetitive transcranial magnetic stimulation. So somebody gets depression in a significant way and not getting better with medicines. We use very high power magnets which are applied onto the brain and focused at specific areas and repeatedly stimulating the brain. And that seems to interestingly produce good recovery from depression. The other therapies would be gene therapies. We are very far away from trying to really locate the specific genes for specific illnesses. But now the focus, especially certain gene loci or gene sites, have been identified for schizophrenias, addictions, and there are lots of what we call as putative genes, or most likely genes which are involved in the processes in causation of mental illness and maintenance of mental illnesses, which can be addressed or targeted, and especially looking at intranuclear process, the cell nucleus of the brain. So in order to ensure that these things are addressed, gene therapies are something which are in the pipeline and they might get better. So these are major treatments, and of course there is something called psychosurgery, which I did talk about earlier, sort of in 30s and 40s. Somebody called Monet has probably done more lobotomies, wherein they used to disconnect the brain, the front part of the brain, using a sharp snare or a knife. They were sometimes too crude to even sterilize the instruments, and there were times like people used to do 100 surgeries a day. So, and in US, one particular surgeon used to travel from town to town just doing lobotomies. So it was fad of the day for a while, but it's a barbaric treatment when compared to the current times. And now psychosurgeries can be done with very specialized stereotactic guided instruments, wherein you can, certain parts of the brain are actually ablated when there is a problem on a continuous basis, but it's not done on a routine basis. I was talking about medicines earlier. Medication, as I was saying, it's a major source of and major armamentarium of psychiatric treatments. We have groups of medicines called antipsychotics. When we did talk about illnesses like schizophrenia and other psychosis, wherein people lose touch with reality, or when they believe that they're especially gifted when they're not, and when they believe that they're in communication with others, or especially God, when communication is through some incomprehensible method, not just a mobile phone communication, but through some alien spaceship and space waves and that sort of things. They are treated with antipsychotic medicines. Antipsychotics in the past, from 50s, we have moved on significantly. In the 50s, they used to have something called chlorpromazine, and as it went on, there has been drugs like haloperidol, trifluperazine, and various other drugs. And since 80s, things have changed dramatically, especially as we moved into 90s and 2000s. There is something called second generation or atypical antipsychotics, which have lesser side effects, but unfortunately, they still continue to have some more side effects. We're still far away from an ideal antipsychotic, but things are much better. And for depression, we use antidepressants. The first, again, in 50s, we had imipramine, and which was used in tuberculosis, and we found a compound which works similar to that. So from there, from what we used to call as tricyclics, tetracyclics, there are now newer medicines called SSRIs, or serotonin specific reuptake inhibitors, or newer ones like serotonin norepinephrine reuptake inhibitors, or SNRIs, and newer modes of antidepressants. Antidepressants are used in depression, and there are now much more refined antidepressants which cause lesser side effects. And there are a group of medicine called anxiolytics used in treatment of anxiety disorders, and also in obsessive compulsive syndromes wherein people continue to wash repeatedly or check the dose repeatedly, the obsessive compulsive disorder spectrum patients. Then we have anti-craving agents. Earlier, when people were suffering from alcohol dependence or cannabis dependence or any other dependence or addictions, we were just able to detoxify them, but not able to continue to follow them in the community or prevent them from consuming these substances all over again. So there is now a much more impetus on anti-craving agents. And with the advent of modern problems such as internet addiction or other forms of addiction, anti-craving agents seem to play a major role in preventing relapse in these patients who have addictions. There is now more money spent on nootropics or brain enhancing products, especially in conditions such as learning disabilities like Down syndrome, wherein there is a underdevelopment of brain because of repetition of 21st chromosome, which has, in Down's patients you have 3 copies of 21st chromosome when you actually need only 2 copies. So which leads to decrease in brain's functioning or learning disability. Nootropics or brain enhancing drugs seem to play a major role. We are still far from an ideal nootropic, but still lots of firms are investing, pharmaceutical companies are investing in developing an ideal nootropic. Interesting things have happened in care of dementia in the recent past. Dementia, as we discussed earlier, is a cognitive decline which is globally affecting a person's ability to function and predominantly presents as a memory problem. Now we have drugs which slow down the progress of dementia. We don't have a drug to treat dementia completely, but we have drugs to slow down such as donepezil and rivastigmine, which help in slowing down the processes of dementia, thereby actually providing a better quality of life for patients who are suffering from either Alzheimer's dementia or frontotemporal dementia or Lewy body dementia. And in treatments of epilepsy and epilepsy-related psychiatric complications, now we have fine-tuned drugs which prevent seizures and also behaviors associated with seizures. So psychiatric armamentarium, especially pharmacologically, things have been much better in comparison to the past. We have drugs which are less addictive with less drug-to-drug interactions, especially because when we use in elderly patients, they might have already been using other medicines for diabetes or hypertension. So these drugs are relatively safe in comparison to the old drugs because they are less likely to interfere with other treatments and other medications, and are less likely to become habit forming and less likely to have more and more side effects. When we did talk about biopsychosocial approaches, the biological approaches we did deal with, we spoke about pharmacological or medicine-based intervention, electroconvulsive therapy or shock therapy, which is used in severe depression. Still, it's a valid tool for treating severe psychotic, suicidal, depressed patients. And it's not as bad as people talk about in the press, and it's received a bad press, but it still continues to form a very effective form of treatment for severe depression with psychotic symptoms. When a patient is suicidal, ECT works very well for these patients. And then we did talk about repetitive transcranial magnetic stimulation and vagal nerve stimulation and psychosurgery, apart from other treatments like direct brain stimulation and deep brain stimulation, wherein electrodes are put deep into the brain of the patient to improve their cognitive ability, or refractory or treatment resistant depressions. The other major tool which we psychiatrists and psychologists and psychotherapists have is talking treatments. People have this big notion like, talking treatments means you go and lie down on a couch and you tell about your problems, or you talk about your mother and past. Talking treatments have gone much further from the old Freudian ways of thinking, wherein psychoanalysis was a major tool. If you look at psychoanalysis, primarily works with your unconscious mind and subconscious mind, and your development from the past and your relationship with the mother and the way you form relationships. Psychoanalysis, if you look at, is evolved much from Freudian models, wherein you see psychoanalysis based treatments like Freud and Jung needs a degree of free association. So people are asked to lie down on a couch and talk about their issues, and a therapist stays there as a passive observer and provides inputs into the patient's mind space and looking into the space and helps to heal. But that's a very long drawn process. It can take many years and several years. But now the newer forms of treatment like cognitive behavior therapy looks into the here and now approaches, which is much more directive. It helps in trying to understand the problems, the errors in cognitive thinking. For example, a patient might come in and say like, oh God, I'm a useless person. So when you ask them, why do you think you're a useless person? Oh, my boss scolded me. Why did he scold you? Oh, for no reason, I don't know why. So why a boss scolding a person makes him useless? So challenging that negative schema. And sometimes people can have arbitrary inferences, wherein people make assumptions based on very little data or no data. And sometimes people can have catastrophic thinking. If they're late by a few seconds to work or to any place, they might think, oh God, people are going to hate me, or things are going to fail, or I'm always a failure. So these sort of catastrophic thought processes are addressed very effectively by cognitive behavior therapy, and it's a very time-limited therapy. So it goes on for about 12 to 16 weeks, at the most 18 weeks, and the whole thing is packaged very well, and it's got very effective and measurable outcomes. An interesting bit is that with cognitive behavior therapy, looking at brain imaging and functional imaging, there is evidence to say that people who undergo cognitive behavior therapy for depression seems to form new connections in the brain. So thinking does make a difference to the structure of the brain. So these therapies are effective in not just changing your thought process, but the structure of your brain. So cognitive behavior therapy not only increases the circulation to the front part of the brain, the hypofrontality we did talk about in major certain illnesses, that seems to get better with cognitive behavior therapy. Other forms of therapy are interpersonal therapy. Patients who have issues dealing with the interpersonal issues and become depressed. So interpersonal therapy is a very effective therapy. And in patients who have this repetitive self-harm behavior, like cutting themselves, or taking overdoses, or threatening to hurt themselves, or being dramatic in their relationships, having quick, brief relationships and breaking down of relationships, idealizing and demoralizing or denigrating people from very quickly. So these people get better with what is called a DBT, or didactic behavior therapy. And we sometimes use something called systemic therapy, it's especially used in families, looking families as a system and how systems can be influenced to cause change in the dynamics of the family. So systemic therapy and family therapy are very effective tools, and some clinicians, especially psychologists and psychoanalysts and psychiatrists, use what is called an eclectic model, wherein it's a combination of therapies which are borrowed together, but one core principle which seem to go through all the therapies, irrespective of psychoanalysis or cognitive behavior therapy or didactic behavior therapy or DBT or whatever, is that there is something called unconditional positive regard. So you have an unconditional positive regard for your patient is the core principle underlying the talking treatments. These treatments are different from befriending, lay counseling. These are proven scientific therapies, and when a person needs these therapies, they are to be done by a qualified person, somebody who's got experience and qualifications from a qualified university, and not a lay person. And in the social approaches, we talk about biological, psychological, and social approaches. So we discussed biological approaches and psychological approaches in the previous few minutes. When we look at social approaches, simple things as we spoke about, trying to ensure that an individual with psychological illness or mental illness is integrated back into the society, not treating them as pariahs or somebody who's to be sort of treated differently. Try to treat them as normally as possible, make them feel that they're part of the mainstream society and not different, and ensuring that their basic needs are met, such as social respect, dignity, and human status. Because it's very tempting to confine the person with psychiatric illnesses to a different place. You do come across families who don't let their psychologically ill come into the front room when friends or guests arrive, or there is a sense of disconnect with the society. They're not allowed to play with other children. So there is a need for social education to make this integration happen, both at a community level and a societal level, and also at a national level. And the children with learning disabilities need comprehensive assessment, because integration, there's a need for social needs assessment, whether the child's educational needs are met, whether the child's moral needs are met, whether the child's emotional and stimulation levels are adequate. So these sort of social assessments will have to happen, be looked at. And also society needs certain specialized people in dealing with abuse of children with mental illness, or elderly even with mental illness. So ensure that neglect and abuse doesn't take place for these individuals. Apart from these issues, we need to look at occupational therapy. People who are into employment, a full-time employment with mental illness, are less likely to have a recurrence or relapse of illness. So having a steady job and a steady relationship is a very good indicator of better prognosis of mental illness. So social interventions in terms of relationships in the family and an occupation is very important from social outcomes point of view. And if need be, there needs to be a training for people, especially with autism or schizophrenia, for social skills training. They might not have the ability to wait for their turn. If they're in a meeting, they might just blurt out answers, or they might not really wait for things to happen, or they might just go about speaking inappropriately. So a bit of social skills training and assertiveness training, like understanding and expressing their own needs, and being able to communicate their ideas, and being able to say no when, especially like this learning disabled children, especially women who are likely to be sexually exploited and abused. That's where social skills training and need for social intervention is absolutely necessary. So we have discussed biological approaches in healing minds, we have discussed psychological approaches and social approaches in healing the minds. Now we quickly run through what are the factors or hurdles which come in the way of treatment. In India, along with many other nations of course, stigma is a major barrier. Mental illness is considered a taboo. Mental illness has to be swept under the carpet. Nobody should know that somebody has mental illness. And people are more happy to sort of stand in a queue for a very sort of less than decent movie, but they would not want to go to a psychiatrist or a mental health professional for help, or they don't want to be seen in the waiting rooms of a psychiatrist or a mental health professional. Things are changing, much better than what it was perhaps 25 years ago, but there is need for much more awareness. Much more awareness in terms of being aware that mental illness is treatable, people get better, and it's something which is similar to or akin to diabetes or any other hypertension or any other physical illness which needs treatment and getting better. And other major hurdle is lack of insight, because the observer himself gets unwell. As I was telling earlier, if the brain which observes the whole of the body gets sick, how is it going to know? So people believe that, oh, there is nothing wrong with them, or it's something which will go away, or everything is fine, I don't have any pain, why should I go to a doctor? Wherein they're still neglecting themselves, they're not taking care of themselves, they're wanting to end their lives. So there is lack of insight which comes in the way of treatment. And sometimes people go and see a doctor and start feeling better, and doctor advises or a psychologist advises that they need treatment for a year or what, or longer period. People think, oh, now that things are better, like a diabetic patient, like, oh, sugar levels are better now, I might stop the treatment. So there is a possibility that people might get themselves undertreated because they're feeling better, they stop the treatment and get unwell again. And prejudice not just about people with mental illness, but prejudice about the specialty or the treatment itself. People think, oh God, I mean, if I go to a psychiatrist, they're going to prescribe me lots and lots of medicines. Or they might think that, oh God, they're going to shock me or give shock treatment. Or they might think that they're going to give drugs which are going to make me feel like a zombie for the rest of my life. or they might think like, oh, they're going to give me drugs which are going to make me an addict to these drugs. I don't want to be taking drugs to feel better or get better. So there are lots of biases and prejudices and stigmas attached to the particular treatment models. As I was telling earlier, treatments are very safe these days. They're very effective. They're likely to, have very good outcomes, and it integrates people much more better into society. And stereotypes and assumptions about mentally ill is something, it's a part of stigma. Mentally, like the words they use, like, oh, this guy is mad, or this guy is on pills, or this guy's kids, or whatever. These sort of individualized stereotypes, or people at work, oh, don't bother him, he goes to a psychiatrist. So at work or whatever. So there is a need for society to educate into these models of care, reduce the stigma, bring more awareness, and get a feeling that psychiatric illness or mental illness or illness of mind are like any other illness of the body, like diabetes or hypertension or anything, and they're treatable. Now medicines are much more effective, and the treatment research is much more into evolving, fine-tuning the care into getting things better. In summary, we have looked at the history of treatment or ways of healing minds from medieval times to the Renaissance period to the early 20th century and late 20th century. Now we are at a very interesting time. We have at least defined treatments for almost all major psychiatric illnesses. We might not have a panacea, but there are definite treatments, and the research is on for much more fine-tuned treatments, and we are in an exciting time in terms of healing minds. And let's all join together to make this place a better place for mentally unwell people, and let's contribute towards healthier minds.